Saptarshi sir, after 30 seconds, please start.
See, we will start in 30 seconds, right? So, Dr. Lavina, she's a DM resident in UCMS. So, she's our master of ceremony.
Hi, Lavina. Yes.
Hello, sir.
So she will coordinate the sessions and she will invite. So, just the opening remark will be from Dr. Lavina and she will invite Dr. Wangnu. Welcome, Dr.
Hi, sir. Hi, sir.
Hi, hi.
Hi. Hi.
Hello. Good evening, sir.
Good evening.
Good evening, everyone. I welcome you all to this program on awareness about pre-diabetes, which is being hosted by the Endocrine Society of Delhi on the occasion of World Pre-Diabetes Day. I firstly invite Dr. Subhash Kumar Wagnu, the immediate past president of Endocrine Society of Delhi, for the welcome address.
Thank you very much. I think my dear colleagues and everybody, nice to interact with you. And today being the World Pre-Diabetes Day, let's ponder. We start with the pre-diabetes along with the diabetes and obesity is rising in an exponential term all over the world, but in particular among the Asian Indians. I think the first ever study which was done by Dr. Mohan, CURE study, the Chennai Urban Rural Epidemiological Study, the figure that was shown in the CURE study that the incidence of diabetes, pre-diabetes, and the dysglycemia was around 22, 30, and 55%, 52%. A rising incidence of all the three pre-diabetes, diabetes, and dysglycemia. The second, I want to just discuss with all of you that being labeled as a pre-diabetes, whether we should label as a pre-diabetes or early diabetes, another nomenclature, because both have some advantage and disadvantages. Whether we should label early diabetes or pre-diabetes, you can ponder upon what are the advantages and the potential drawbacks. Then coming to the pre-diabetes grading system, mild, moderate, and severe, what clinical implication it has on the treatment part, whether we have to the mild, moderate, and severe. And lastly, but not the least, that we have to how we can screen the risk factor about the pre-diabetes. Family history, obesity, increased BMI, increased waist circumference, sedentary lifestyle, smoking, alcohol, and in female past history of PCO, recurrent abortions, everything you have to keep in mind the multiple risk factor for the development of the pre-diabetes. And these are the points to ponder the Delhi Endocrine Society, whether the grading system is going to help, whether the nomenclature, change the nomenclature is going to have some advantages, and how we can strategize our population for the early screening, early diagnosis, and recommending the intervention at the appropriate time. We have so many trials which have shown that the proper intervention at the proper time will lead to the decrease in the incidence of the conversion of the pre-diabetes to the diabetes. And that is very important, whether it was DPP, whether it was the Indian Diabetes Prevention Program. There's so many other, even the first was what you call with the glucose, the first to see whether the pre-diabetic patient can be prevented to develop converted to type 2 diabetes. Stop Needham trial. I think with this opening mark, we have galaxy of stars and the speakers are going to dwell upon the various aspects of the pre-diabetes. Let's listen to them and then we can come to some conclusion. Over to you for your further scientific agenda.
Lavina.
Thank you, sir, for your insightful words. I would now like to invite Dr. Nishant Raizada, Associate Professor and Head Department of Endocrinology at UCMS Delhi, to discuss about the topic Natural History of Pre-Diabetes.
Thank you, Dr. Lavina. My video would driven off because my network is a little weak. I'll go ahead and share my screen. I hope slides are visible.
Yes.
Yeah, thank you. So, thank you very much, Dr. Lavina. I'll be briefly discussing an introduction to prediabetes and some aspects about the natural history of prediabetes worldwide as well as in India. So let's begin with the definition. So as we know, prediabetes is an entity which lies in between normoglycemia and diabetes. And there are broadly two main criteria which have been used to define prediabetes. One is the American Diabetes Association criteria or the ADA criteria, and the second one is the WHO criteria. According to the ADA criteria, there are three basic points: a fasting plasma glucose between 100 and 125 milligram per DL, or a 2-hour post-glucose value of between 140 to 199. And the third criteria is that of the A1C and A1C between 5.7 and 6.4%. Now, the WHO criteria is slightly different. WHO criteria states that instead of the fasting plasma glucose being 100 to 125, WHO says it should be 110 to 125. So these criteria have been established in the terms to predict the risk of developing diabetes, and WHO felt that the cutoff of 110 better represented the risk of diabetes than a cutoff of 100. And the other difference in the WHO criteria is that WHO does not include HbA1c as one of the criteria. This particular aspect regarding HbA1c is particularly relevant to our setting, where a lot of females may have iron deficiency anemia. And this study by Dr. S.P. Madhu and his group showed that patients who had iron deficiency anemia and who later have been corrected for with iron deficiency, they actually decreased by almost 0.5%. So that would be enough to completely change the person's assignment from prediabetes to normoglycemia, and therefore we should be cautious when using HbA1c to diagnose prediabetes in the Indian population. This slide shows the natural history of type 2 diabetes. This is a very simplistic model, which assumed in the beginning that type 2 diabetes began with only insulin resistance. So insulin resistance would gradually increase around 10 to 15 years prior to the onset of diabetes. And in the beginning, the beta cell function would be maintained. In fact, the insulin levels would be high. They would remain high, and they would try to counter the insulin resistance, and thereby maintaining the glucose in the normal values. But subsequently, as the resistance would increase, the beta cell would gradually tire out. And as the insulin secretion would not be able to cope up with the insulin resistance, then the blood begin to rise slightly. This is the point out here where the postprandial plasma glucose would post-glucose load glucose would value would go above the cutoff. This model assumed that there is no beta cell dysfunction to begin with, but we know that there is enough data from India to show that even in the early phases of prediabetes and diabetes, beta cell function dysfunction occurs, and therefore the actual pathogenesis is a little more complex. But for the sake of understanding, this is a useful diagram. So now moving on to prevalence of prediabetes. So the prevalence of prediabetes can be estimated, but it is complicated by three entities. Prediabetes can be impaired fasting glucose alone. That is the first criteria. It could be impaired glucose tolerance alone. That is the second criteria. And it could also be a combination of both IFG and IGT. And of course, the fourth one would be HbA1c. So according to ADA, a recent publication, they have mentioned that overall the global burden of prediabetes is such that around 9% of people have impaired glucose tolerance, whereas another 6% have impaired fasting glucose. So important to note that globally speaking, impaired glucose tolerance is the dominant abnormality, and the second one is being the impaired fasting glucose. And they estimate the prevalence is going to grow substantially worldwide, and we need interventions to prevent the progression to diabetes. Now we come to Indian data. The largest Indian data is, of course, by the ICMR INDIAB study. And according to this, they found that if we use the WHO criteria, where the fasting plasma glucose was a minimum of 110, then the prevalence is 15.3%. And out of this, 10.1% is impaired fasting glucose. On the contrary, if we use the ADA criteria, which is more broader, then the prevalence goes to a staggering 32.8%, with 27.6% being impaired fasting glucose. So this is the implication of using ADA criteria, which is a little more wide in terms of including patients with prediabetes. And this slide shows the state-wise prevalence of prediabetes prevalence based upon the WHO criteria. And you can see that most of North India, including Delhi, is in the more than 15% group, which is the red in color. And a large parts of the country are between 10 to 14.9, which is this light pink color. And only very few areas, Punjab and Jharkhand and some northeast state, having a prevalence between 5 to 9.9. And I can barely see any green on the map, green as area where the prevalence is less than 5%. So now we come to natural history of prediabetes. So natural history of prediabetes from the global data, one of the older study being the Inter 99 study. This was done in Steno in Denmark. And they reported that the conversion of prediabetes to diabetes is around 4% per year in the combined low and high risk groups. Whereas in the high risk groups, those having smoking, those having dyslipidemia, hypertension, or obesity, this conversion would be as high as 5%. But there's an important flaw that this inter-99 study was not an observational study. It was actually a study designed towards lowering cardiovascular risk. So there was some intervention which was ongoing, and that intervention could have reduced the progression of prediabetes to diabetes. Another meta-analysis published back in 2007 reported that around 5 to 10% of patients with prediabetes would progress to diabetes per year. And a more recent meta-analysis reports that 3.5 to 7% per year conversion would occur from prediabetes to diabetes compared to only 2% in those with normal glucose tolerance. And they reported that the highest rate of conversion would be in those who have IFG plus IGT, and the lowest rate of conversion would be those defined as IFG by the ADA criteria, but not by the WHO criteria, as in those having a glucose between 100 and 110. Further, it is reported that if you have an A1C between 5.7 to 6, then the conversion rate is around 5% per year. But if the A1C is more than 6.1, then the conversion would be 10% per year. What about diversion from prediabetes to normoglycemia? Do people remain in prediabetes permanently, or they only go to diabetes? Can they come backward also? So there is enough data to show that a lot of people majority of people would actually revert back to normoglycemia. In the Whitehall 2 study, based upon the fasting plasma glucose criterion, they found that at end of 5 years, around 45% people with prediabetes were reverted to normoglycemia, whereas 14% progressed to diabetes. Based upon the 2R post-glucose value, they found that 37% reverted to normoglycemia, 23% progressed to diabetes, and at the A1C criteria, 17% reverted to normoglycemia with 14% progressing to diabetes. And a Cochrane systematic review published in 2018, they found that within 1 to 5 years of follow-up, up to 33 to 59% of patients can actually become normoglycemic, and in 6 to 11 years of follow-up, actually up to 42% can become normoglycemic. So this gives us hope that prediabetes can be reversed to normoglycemia, and we can adopt more lifestyle measures, as Dr. Wangnu sir suggested, to increase this conversion rate even further. Even among older adults, there is a study from the ARI cohort in which the mean age of the population was 75 years, and they followed them up for 5 years, and they found that only 9% progressed to diabetes and 13% regressed to normoglycemia by the A1C criterion, whereas based upon the impaired fasting glucose criterion, only 44% regressed to normoglycemia. Now, we have recent publication from India. This is the data from the CARS study, and they have reported the time to progression in Indian patients. And they had out 2,714 patients with diabetes, and out of this, 641 had impaired fasting glucose and 341 had impaired glucose tolerance. To contrast this to the international data, in which the majority of the people had impaired glucose tolerance and a smaller number had impaired fasting glucose, in Indians, it appears that impaired fasting glucose is the dominant abnormality, and which signals a little bit towards early beta cell dysfunction. Then, and what is the annual transition to diabetes? They found that impaired glucose tolerance conversion to diabetes was as high as 13.9% per year, whereas that for impaired fasting glucose was 8.6% per year. And they also reported that on an average, people reside 35 to 40 years in normoglycemic states, but only 9.7 years in impaired fasting glucose and 6.1 years in impaired glucose tolerance before advancing to diabetes. This indicates that the window for action is a small one. People remain normoglycemic for many years, but they remain in prediabetes for a very short span. And whenever we find a patient with prediabetes, we have to be very aggressive in bringing them back to normoglycemia. So that is basically the end of the presentation. I will just mention some take-home points. The ADA and WHO criteria, they differ in terms of the fasting plasma glucose cutoff, and also HbA1c is there in the ADA, but not in the WHO criteria. HbA1c may not be reliable for prediabetes diagnosis in many Indians, especially those having iron deficiency. The prediabetes prevalence in India is much higher than the global value. In Indians, impaired fasting glucose is much more common than impaired glucose tolerance, and Indians have a much faster rates of progression to diabetes from prediabetes as compared to the global population. So we need to intervene even more in Indian populations. Thank you.
Thank you, sir, for such an informative presentation. I next invite Dr. Amrish Mittal, President of Endocrine Society of Delhi, to discuss on the topic, is there a need to have guidelines for prediabetes in the Asian context? Dr. Amrish.
Thank you, Lavina. Thank you. I'll just share the screen. Yeah. Am I audible and visible?
Yes, sir.
Yeah. So we're all talking of pre-diabetes, and I'll first echo what Dr. Wangnu said about the semantics also, because there is a bit of a challenge, I feel, in giving it a pre-diabetes label. We are doing that, of course, because it sounds like a disease per se, which means that if you look at pre-diabetes and diabetes combined in metros at the age of 60, for example, 75% people probably have some amount of glucose abnormalities. So if diabetes plus pre-diabetes in Delhi at the age of 60 would be 70-75% of the population. So there is a school of thought, and one can agree or disagree whether it should be described as because once you give it a label, it's described as a disease, So people tend to sort of panic. And while we do want people to be aware that about pre-diabetes, we don't want people to think of them as diseased. Even in diabetes, we are not using the word diabetic anymore. So I'm just saying that there's a little bit of a social, psychological factor here in labeling everyone. But anyway, going by the global definitions, we do have pre-diabetes very well outlined by Nishant. Do we need to have guidelines in the Asian context or Indian context? Yes, firstly, I do think that the numbers are huge. So as I said, in metros at the age of 60, but in the whole adult population of India, almost all states covered, you would find that the total number of people with diabetes is 100 million and total number of people with pre-diabetes is 136 million. So quite clearly, pre-diabetes is actually outscoring diabetes. Happens is that there is
So there is some issue with the presentation, sir.
rise in pre-diabetes throughout.
Sir, maybe you can switch off the video and just share the screen,
At
because
some point, when
I think there was a connection error. Dr. Wangnu, you want to ask Dr. Nishant anything about his presentation? Any comments about the progression and what you have been seeing? Sir, you are muted. Sir, you are muted.
Yeah, I think it was well presented by Dr. Nishant, and he has already highlighted the difference between the Asian Indian phenotypes compared to the rest of the world, that the conversion rate is high. That is why our screening age should be a bit lower as compared to the rest of the world. I think RSSDI guidelines says cutoff age of 35 years. After that, you should start screening for the pre-diabetes. And most of the time, I see this risk factor for the development of the pre-diabetes. We have a very distinct Indian phenotype where we have the insulin resistance predominantly around the waist, and the waist circumference becomes a very important criteria. Waist hip ratio becomes a very important criteria. BMI, the PCO girls having tendency to go into pre-diabetes. Some of the other data which has emerged from the CURE study, later on and the follow-up is that how different the Indian behaves as compared to the rest of the world. Whether there are any ethnic differences between north, south, east, and west, that should be also be highlighted. I think Ambrish has come.
Yes, sir. So,
Sir, mute है आप.
sir, you are muted. Sir, you are muted. Dr. Mittal, you are muted, sir.
Yes, I don't know what happened. I'm okay now.
Now you are visible.
Am I audible?
You are audible also.
Hello?
Sir, maybe you can switch off the video and only share the screen because otherwise bandwidth seems to be slightly low on your side.
Okay, thank you. I kept talking and there's a connection. Okay, I said I continued to talk, and after some time I realized that I'm logged out actually, and I'm talking to. So anyway, coming back to this, so the thing is that pre-diabetes and diabetes, as Subhash
I think some signal issues there. Ambrish should try with your iPhone, I think, not the laptop. That will be better option. Can you continue with the next lecture for the time being?
Yes, sir.
Amrish is,
if
Dr.
I'm
Amrish is
audible,
joining back.
then
Or
I'll,
if
then I'll,
yeah.
if I'm audible, I'll talk without the slides, okay? Is that
You are
okay?
Sir,
You're
you
audible.
can share the slides, but don't switch on the video. So that will be,
Okay, last
that
try.
won't take much of bandwidth.
Last try. I don't know. Is that okay?
Yes, sir. Yes, sir. This is fine.
So I was talking about the numbers going up. We also know that the lifetime risk of developing diabetes in someone who has pre-diabetes is 70%. The 5-year risk of developing diabetes, as Nishant presented in an annual kind of data, this is the 5-year risk. If you have A1C between 6 and 6.4, then it's 50%. And if you're at below that, if you're between 5.7 and 6, it's 25%. So there is a big sort of issue there. So one risk of pre-diabetes is that it leads to diabetes. So it should also be called meaning prevent diabetes. We can prevent that progression. So the other risk is that as such, pre-diabetes increases the risk of coronary artery disease, of coronary events and others. So that also is an issue. Both stroke and coronary events increase even in the pre-diabetes stage. Now, however, having said that, weight is the major thing. Weight loss is the major way to prevent progression of pre-diabetes to diabetes. We all know that. We all know the direct study and so many other studies. Direct study was more for remission and established diabetes, but the diabetes prevention outcome study, you can clearly see that if you lose weight in the DPP, you reduce your risk of developing diabetes. A change in weight from baseline, as we lose more weight, the risk of developing type 2 diabetes goes away. So therefore, one single line message from this is, if you're at the pre-diabetic stage, it's important to have people lose some weight. But I wish it was as simple. So this varies 5 kilogram, 10 kilogram, 15 kilogram, 5%, etc. The issue is that it depends also on the fact that these are Western studies and the amount of weight loss they're seeing is more, the amount of obesity they're seeing is more. So maybe the numbers may not be exactly the same for us Indians. And this is equally important to realize that not all people with diabetes actually have severe insulin resistant diabetes. So, I mean, in this data, it shows, this is again Mohan's data, which shows about 25% of people have severe insulin deficient diabetes. In my experience, that number seems to be less, but there is no doubt that there are some people who at onset of diabetes are already insulin deficient. So, for example, this again is talking about diabetes remission, but the same thing will apply to pre-diabetes. That if you are pre-diabetic because of predominant insulin deficiency, even though if you're type 2, then the simple weight loss strategy may not work. Okay? So I think that is an important thing to remember. Not all patients are the same. We get people with relatively lean body habitus who are also pre-diabetic and therefore trying to just help them to become normal or remain pre-diabetic without conversion may not be the best strategy. But rest of them, of course, it's a good thing. Of course, remember that in mild age-related diabetes also, it's not so much of a significant thing to try and prevent conversion. So it's the middle groups that are the most important. And the interesting thing here is that, in the INDIAB study group, what they showed was that both in people with newly diagnosed diabetes and pre-diabetes, some reduction in carbohydrate and increase in protein, not a drastic reduction, not like Roy Taylor's data of 800 calories, etc. Just a reduction in simple carbs of 10%, increase in protein of 7-8% was able to reduce significantly the conversion from pre-diabetes to diabetes and increase the actual remission, which means remission of pre-diabetes to diabetes occurred with some changes in diet, which were not as drastic as seen in Western populations. This, I think, is really important and really does suggest that we should have somewhat different guidelines. This, of course, you all know. This is a small study, but it's a neat study, so I just put it in there. It's only 32 patients with newly diagnosed type 2 diabetes. And follow-up was 2 years. Now, let me just simplify this and look at the blue text box at the bottom. This is a small study, but it shows some kind of data that we see in corporate practice. 75% of young adults with newly diagnosed type 2 diabetes achieved remission of diabetes at 1 year. This is again borderline diabetes versus pre-diabetes, and you see that there is a very high remission rate, again indicating the importance of change in caloric intake. In those who were able to reverse, they had reduced their caloric intake by 1,000 calories. Those who did not reverse had reduced their intake by 500 calories, or 450 calories. And of course, the weight was different. So again, this is very early diabetes, or you can call it overlapping with pre-diabetes. But the fact is that it did show reversal. So you can say that study actually looked primarily at people who were diagnosed, so it doesn't really apply. But I think this is a very important. This German study published late last year is, I think, really important. This is the pre-diabetes lifestyle intervention study. This is looking only at pre-diabetes. And they had some non-responders and some responders. When you look at the baseline group, and if you look at those who lost at least 5% of weight, right? Within those who lost 5% of weight, some were non-responders, some were responders. What determined those who responded or who didn't respond? So when they looked at liver fat, it was equally reduced. So you say you have two groups of pre-diabetes, you lost more than 5%. the liver fat reduction was the same. But the visceral fat, omental fat around the intestines, pancreatic fat, all that significantly went down in the responders. So despite similar gross weight loss, like overall weight loss, those who lost more visceral fat clearly were the ones who responded by going into remission from their pre-diabetes to diabetes. And insulin sensitivity increased, and they did whole body insulin sensitivity studies, etc. Now, the important point here is that this is specially applicable, could be specially applicable to Indians, where abdominal obesity is a dominant obesity. And therefore, visceral fat reduction is the key, even if the weight loss is not that significant. I mean, don't have to have that 15 kilogram, 10 kilogram weight loss that the Western studies talk about. I think this is the point that we have to understand, that it's not just checking the weight going from 100 to 95 kilograms. A lot depends on the reduction in visceral fat that reduces inflammation, increases insulin sensitivity, and therefore those who have a reduction in visceral fat and reduction in inflammation are less likely to develop type 2 diabetes despite having similar weight loss. And this, of course, is our young friends. Nishant is part of this. He's here. I don't know if Rajiv and others are here. But clearly, this is for those with established diabetes. So we can leave this out, but the concept is the same, right? This study has already been alluded to by Nishant, so I won't go into that. The important part is that I've been seeing this all the time, and I'm so glad it is now agreed upon that impaired fasting glucose is commoner than impaired glucose tolerance, contrary to what all the Western data shows. And equally important is the fact that annual transition time is 13.9% for IGT versus 8.6 for IFG. So I think this is important. This is based on modeling, actually. This is the Markov model, which is a dynamic model and statistical model that predicts the development of diabetes. So we can leave this. This study has already been discussed. The important point here is, yeah. Hello? Hello?
Yes, sir, please go ahead.
Yeah. So just to emphasize, sorry for all the interruptions. This is the place and this is the connection where I do all my programs. I don't know what happened today. Maybe 15th August. So anyway, so the thing is that one important point was raised by Nishant about the fact that A1C, using it solely for the diagnosis is a challenge because of iron deficiency anemia and iron replacement. Number one. Number two, the fact that our conversion rates to frank diabetes are higher, faster. And number three, that a significant proportion of Indians may have beta cell dysfunction even in the pre-diabetes stage. I think these are the 3 points which do suggest that we need to have some kind of broad guidelines, nothing complicated, for prevention of diabetes and for people who are pre-diabetic already to reduce the risk of other complications. Thank you.
Thank you, sir, for highlighting it excellently on such a relevant issue. I would now like to invite Dr. Parjeet Kaur, Associate Director, Department of Endocrinology at Medant Hospital, Gurugram, to shed light on the next topic, prediabetes and metabolism-associated steatotic liver disease. I also welcome the panelists for this discussion, Dr. Narendra Singh Chaudhary, Associate Professor in Department of Hepatology at Medant, Dr. M. Shafi Kuche, Consultant Endocrinologist at Medant Medicity, Dr. Anupam Biswas, Consultant Endocrinologist at Fortis Noida. Dr. Parjeet Kaur.
Yeah, hi. Thank you. Very good evening to all. So we'll be discussing about pre-diabetes and MASLD. Hope I'm audible and the slides are visible.
Yes, ma'am.
Yeah. So I'll just start with the case discussion, small case to start with, which is a routine daily case which we see in our clinical practice. Here is a 40-year-old male with a medical history of hypertension, obesity, and borderline high cholesterol levels, with family history of father being diabetic, mother has hypertension and dyslipidemia. He has a sedentary lifestyle with minimal physical activity. Diet is also not very good. And he comes for a routine checkup where examination reveals that he is obese. His blood pressure is also slightly on the higher side, and he has signs of insulin resistance in the form of acanthosis. His lab result shows that his fasting blood glucose is high, 112, and HbA1c is 6%, which points towards that he has pre-diabetes. His lipid profile is showing high LDL with high triglyceride levels and low HDL. His liver functions are also deranged with high SGOT and SGPT, and ultrasound shows that he has fatty liver. Now, this patient comes to you, and we all know that patients are worried about these results, especially about the fatty liver, which they see in the ultrasound. They have many questions to ask. So let's ask my panelists today and clear all those doubts. So my first question is to Dr. Narendra Singh. So Dr. Narendra, can we, by looking at these just lab reports and clinical examination and history, can we make a clinical diagnosis of MASLD in this patient? And what is the spectrum of MASLD which you see?
Hi, Dr. Parji. So yes, we can make a clinical diagnosis of MASLD. We require exclusion of significant alcohol intake and hepatitis B and C. If these are negative, then yes, it is MASLD. It is fatty liver plus one of the metabolic risk factors. Actually, this patient is suffering from several metabolic risk factors. Earlier, we used to diagnose these patients at advanced fibrosis or cirrhosis, but nowadays, with increasing trend of health checkup, we pick up them early. So in all these patients, so MASLD can present as asymptomatic steatosis. Patients gets ultrasound for some unrelated cause, and then he comes to us that I am suffering from fatty liver. It can be MASH, that is steatosis plus inflammation. It can be fibrosis, sometimes cirrhosis, and sometimes directly without any symptom. These patients come with HCC. So hepatocellular carcinoma in these patients can happen in setting of cirrhosis, can happen without cirrhosis also. So these are all presentations.
Yes, I totally agree, Dr. Narendra. It's very important that we make this diagnosis after exclusion of alcohol intake and excluding other viral markers. But yes, it has a spectrum. It's just not fatty liver. It can be steatohepatitis or cirrhosis. So
we explain these patients that this fatty liver is not limited to liver. It comorbidities affect kidney, affect heart. There can be chances of obstructive sleep apnea syndrome. Some malignancies are more. So we explain all these to
yes,
patients.
it's part of metabolic syndrome. So Dr. Anupam, we have seen this patient has pre-diabetes and still has all those risk factors and MASLD also. So how common is MASLD in pre-diabetes, and what are the risk factors that can predispose an individual pre-diabetes to develop MASLD?
So, in pre-diabetes, there have been various studies, and the studies have reported around 40 to 55% patients of pre-diabetes have MASLD. Now, the terminology has been changed from just NAFLD to MASLD. So now what is important here to know is how can we prevent or progression of MASLD. So what are the risk factors that predispose individuals? The most important risk factor here is obesity and insulin resistance. So you bring down the weight, you bring down the steatosis also. So other factors which can be involved includes a high triglyceride level, a low HDL level, even a high LDL level. Along with that, there have been studies which have reported increased insulin and increased in leptin levels also have positively correlated with fatty liver disease or MASLD. There is a genetic variant which is known as PNPLA1 gene, which is commonly found in patients who have MASLD. So these are certain factors which can predispose to MASLD. One very important factor to remember here is that even in patients who have MASLD, it is important to cut down on alcohol intake because there is a spectrum known as metabolic associated alcoholic liver disease in patients who already have metabolic syndrome, and they continue consuming alcohol.
Right. So definitely the huge prevalence, which you said, 40 to 50% of even pre-diabetes having MSLD. And there are many risk factors, which I think there are many modifiable risk factors, which in fact highlights the role of very early intervention so that we can prevent the development of MSLD. So Dr. Shafi, this is such a high prevalence of MSLD we are seeing in pre-diabetes. So do you think we should routinely screen such patients of pre-diabetes for MSLD? And if yes, then what should be the right screening strategy?
Thank you. Yes, we should screen. I'll talk about guidelines. So we use, endocrinologists and diabetologists use American Diabetes Association guidelines mostly. So they included this fatty liver disease in 2019 for the first time, recognizing the fact that NAFLD, previously now known as MASLD, causes significant, disease burden and also increases morbidity in patients with diabetes and prediabetes. So for the first time in 2019, there was one recommendation that suggested that all patients with diabetes and prediabetes should be screened. For the first time, the guideline appeared and they appeared together for diabetes and prediabetes. Why was this there? Because they analyzed enhanced data from the USA, and they take a large number of patients, like 36,000 patients, and they saw that all those patients who had fatty liver, those who have diabetes, prediabetes, and no diabetes, among those, the two groups, diabetes group and prediabetes group, they have equal cardiovascular risk and morbidity and liver related morbidity after 4 to 5 years of follow-up. So then now we have all the guidelines, especially diabetic guidelines and endocrinology guidelines, suggesting that we should screen for MASLD, both diabetes and prediabetes. Now, I want to make it clear here that what we should screen for, because we have seen that many doctors even they suggest get ultrasound, and they think that we are screening for MASLD. No, recommendation is not that. As Dr. Narendra rightly said, that it's a spectrum. It is fat, it is inflammation, it is fibrosis, and it is compensated cirrhosis. So we have to screen for fibrosis, not for fat. So ultrasound is not important. You have to go to see whether there is fibrosis in the liver or not, because it is the fibrosis that is a risk factor for cardiovascular disease and liver related morbidity. Now coming to the guideline, ADA guideline, its recommendation 1 is screen all patients with diabetes and prediabetes for liver fibrosis. Okay, so there is no confusion. All guidelines except the guidelines of hepatologists, they suggest that screen for liver fibrosis, that is same, but only diabetes. They have not commented upon pre-diabetes group. So for diabetes, for endocrinologists, we have no confusion. All guidelines suggest to screen both. How should we screen? Also, all guidelines from endocrinologists, they are unanimous in this flow chart that you first, if you have a diabetes patient or pre-diabetes patient, you first get FIB-4 score, which utilizes age of the patient, AST, ALT, and platelet count. And it's an online calculator, you get a number. If it is less than 1.3, that means your patient has very low chances of having fibrosis at this time. You give usual care, your diet and exercise and whatever you want, but no special care for liver at that time. If the FIB-4 score is more than 1.3, then you need second test. You need second, risk assessment test. For us, it is usually FibroScan, but there are other tests. For example, one can use ELF. It's not available commonly here. One can use MRE, elastography. It is not present here. But for us, it is FibroScan. Get FibroScan done. If the LSM value is less than 8, then no particular, care for liver at that time. You can usual care, diet, exercise, and other things. If from above 8, and there is here slight debate. Some say above 8 you refer to a hepatologist. But many suggest that if it is 8 to 12 or 8 to 13, you give care yourself, control diabetes, diet, exercise, and some liver-friendly diabetes medication, and refer only when the LSM is about 12 or 13 for, for looking at whether the patient is having cirrhosis or not. So this is the algorithm for screening. So it is up to you whether you refer about 8 kilopascal of LSM or about 13. We usually do about 13. So there is unanimous decision that this should be the flow chart for screening of liver fibrosis in these patients.
Yeah. Thank you, Dr. Shafi, for clarifying it very nicely that just ultrasound is not good enough. We must go ahead and do a FIB4 screening, which is a very easy tool to use in the clinic setting. And if required, then we can go ahead with the fibroscan also. So, Dr. Narendra, now this patient, for example, this case, we do a fibroscan and we get a LSM score of 14. So, and we refer this patient to you. So how do you manage such patients as from the hepatologist point of view, and how frequently you follow them up?
14 suggests cirrhosis, approximately 70% positive predictive value that this patient is suffering from cirrhosis. It may be F3 in 30% of patients. Weight loss is for everyone, irrespective of fibrosis or no fibrosis. So exercise, modification of diet, weight loss, it is for everyone. The recommended medications by Indian National Association, these are saroglitazar, vitamin E, and pioglitazone. Some of the antidiabetics also help us. Statins also decrease mortality in these patients. And in once we diagnose cirrhosis, so then chances of HCC are significantly more, 1 to 2% every year. So in patients with cirrhosis, other than routine follow-up, we get ultrasound and alpha-fetoprotein every 6 months. Cirrhosis patients, I generally ask for blood test every 3 months, ultrasound and alpha-fetoprotein every 6 months. If it is a no fibrosis group, like 12 is significantly high, suppose it comes with LSM of 6 or 7, then we ask for follow-up every 6 to 12 months. In patients with cirrhosis, then it is every 3-month blood test and every 6-month ultrasound and alpha-fetoprotein.
Right. So follow-up is equally important, just not like one-time management. So
sometimes these patients are lost to follow-up and they come with hepatocellular carcinoma. That is very unfortunate.
That's very true. So we need to advise them carefully when to follow up for their from the MSLD point of view. So rightly said, Dr. Narendra, we have some medications. There are some anti-diabetic medications also are being used and then being studied as well. So Dr. Anupam, my question for you, can you elaborate the role of GLP-1 agonists, for example, in such a case who has just pre-diabetes and MSLD?
So, GLP-1 receptor analogs have emerged as a very promising therapy for patients with metabolic associated steatotic liver disease. So, there have been certain trials. The initial was the LEAN trial, which showed the effectiveness of liraglutide once a day in patients with non-alcoholic fatty liver disease, and it showed resolution of steatosis histologically also with liraglutide. Over a period of time, there have been various other trials like the LEAD trial with liraglutide, a trial with semaglutide, and now in the phase 2 trial with retatrutide, it has shown patients with MASH, almost 90% of these patients achieved resolution of their MASLD with retatrutide. So definitely, as we all know, that pre-diabetes and diabetes are risk factors, and studies have shown that patients of pre-diabetes with MASH or MASLD, they have higher cardiovascular morbidity. Although the cardiovascular mortality may not be significantly high as seen with diabetes, but the high morbidity is higher in patients with pre-diabetes. And we know GLP-1 receptor analog across their various trials have shown benefit in their respective cardiovascular outcome trials also. So probably in the future, we will need more trials, although it is not yet FDA approved till now. But in certain patients of pre-diabetes, we are using a GLP-1 receptor analog for resolution of metabolic associated fatty liver disease.
Right, Dr. Anupam. So at least we know that this drug definitely gives a good weight loss, which is needed in such a case. So there is clear indication in many cases to give even in pre-diabetes with MSLD. So Dr. Shafi, now coming on to the another class of drug, SGLT2 inhibitor, I think you are the first one from the whole all over the world to present the data on SGLT2 inhibitors, role of SGLT2 inhibitors and MSLD in type 2 diabetes patient. This was a study led by you, then our center. But what do you think is the role of SGLT2 inhibitors in pre-diabetes and MSLD? And do you think there are any other promising new therapies on the horizon for the treatment of MSLD?
Okay. So first, let us see what guidelines tell us. Guidelines don't give us, instructions for for pharmacotherapy in these pre-diabetes patients, even if they have fatty liver. So they emphasize on diet and exercise. If you can see our patient, his lifestyle is very, it's not up to mark. So in this patient, clearly we have to give structured, diet plan and exercise. Having said that, we know that many patients are not able to do this. We have indirect evidence for SGLT2 inhibitors in prediabetes. For example, we have, 1 year ago, we have a meta-analysis in JCEM. It was meta-analysis of all the big, cardiovascular outcome trials where they used SGLT2 inhibitor for cardiac purpose and for kidney purpose who had no diabetes or who had prediabetes. They saw that those individuals who had prediabetes and were given SGLT2 after average of 2 to 3 years, first there was drastic reduction in the appearance of new diabetes. So it prevented development of full-fledged diabetes, number one. Number two, there were those patients who were on SGLT2 had 2 to 3 kgs less weight after 3 to 4 years time, which we know that even if there is slight 5%, 3% weight loss is beneficial as far as fatty liver is concerned. So if you have patient who is overweight and he is doing diet, but he is not improving, you can give SGLT2. It is off label. We know that it's not recommended, but you can give. We have used it. It gives good, at least short term good result. But there is 2 classes of patient where we can use, we should not use SGLT2 as first line. For example, if you have a patient with prediabetes and he has obesity, not overweight, he has obesity. So if you can use a GLP-1 receptor analog, Dr. Anupam said, that will be a good choice because there we need more weight loss and it will prevent it. So that clear-cut obesity and prediabetes and MASLD, if GLP-1 receptor will be a good choice. If somehow you are not able to convince the patient, then you can give a SGLT2 inhibitor. Second class of patient who are lean. We see many patients of prediabetes who have fatty liver, but they are not obese. They are normal weight. For that class of, individuals, I think SGLT2 inhibitor will be like second choice. First choice will be pioglitazone in that group. So we can use SGLT2 inhibitor in prediabetes and MSLD, but you have to select patient. Don't, it's not a blanket treatment. You have to select proper candidate for this. Okay, another one, are there any promising new therapies? Yeah, there are many. As one group, we know that these GLP-1 receptor and then dual agonists and then triple agonists that Dr. Anupam was mentioning. I will mention another one, resmetirom. It is now FDA approved for this. It's not for prediabetes. It is for those who have fibrosis, clear-cut fibrosis and above. It is not for prediabetes group. It will be approved for prediabetes also. They are now looking for, study because it's a new drug. We don't have study. But suppose you have a patient of prediabetes with advanced fibrosis, then SGLT2 will not probably work. Then you need a stronger drug like resmetirom in that group. And yeah, if you have a fibrosis, you can give newer these drugs that dual and triple agonists. These are the 3 new classes of drugs that are important, that will that are very promising.
Right. Thank you, Dr. Shafi. Now to sum up, I would say that MSLD is very common in pre-diabetes. No doubt 40 to 50% of prevalence is too high. So we must screen, and the guidelines also say that the screening should be there for MSLD in all pre-diabetes patients with the use of FIB4 score and FibroScan, not just ultrasound. And if there is, we find fibrosis on ultrasound, the FibroScan, LSM of 8 or more than 12, hepatologist reference is must for frequent further follow-up and the plan of the treatment. Lifestyle intervention, no doubt, remains the number one choice for this. Weight reduction is very important. And then we have these drugs now, GLP-1 agonists, especially, and SGLT2 inhibitors and the newer therapies, which are promising in the future to be used in the pre-diabetes and MSLD. I thank all my panelists, Dr. Anupam, Dr. Narendra, and Dr. Shafi, for sharing their views and sharing their expertise in such a clinically important topic of pre-diabetes and MSLD. Thank you. And I hand over now to Dr. Lavina.
Thank you, ma'am, and thank you all panelists for your crucial insights on this topic. Next, I welcome Dr. Lakshmi Nagendra, Associate Professor in Department of Endocrinology at GSS Medical College, Mysore, to shed light on the topic pre-diabetes and PCOS. And the panelists for this discussion, Dr. Rupali Goel, Senior Consultant in Assisted Reproductive Unit at Department of Obstetric and Gynecology in Indraprastha Apollo Hospital, Delhi. Dr. M.R. Varun Kumar, Endocrinologist at Vellamal Specialty Hospital, Madurai, Tamil Nadu. And Dr. Aprajita Pradhan, Consultant Endocrinologist at Delhi. Over to you, Dr. Lakshmi Nagendra, ma'am. Ma'am, you are muted.
Sorry, am I audible now? Yeah.
Yes.
So at the outset, a big thank you to Delhi Endocrine Society for giving us this platform to discuss on this crucial topic. So today we'll be discussing about the connections between PCOS and prediabetes. So we all know that there is an increased incidence of prediabetes and PCOS, but most often when patients come to us with PCOS, it's often because of cosmetic concerns. They might come with, increased hair growth, unwanted hair growth, acne, or it's because of their menstrual irregularities. Some have reproductive concerns. They're not able to conceive. But what we don't realize is that PCOS is also a cardiovascular disease risk factor. It also has many risk factors associated with it, which we should be considering for as a CVD equivalent. So to discuss on this topic, we have three eminent panelists with us. So the first question is to Dr. Aprajita. So what are the key metabolic changes observed in women with PCOS that predispose them to developing prediabetes?
So in PCOS, insulin resistance is one of the key elements underlying the pathogenesis of PCOS, and which is also the main factor associated with development of prediabetes and diabetes in these cohort of patients. And if you talk about insulin resistance in PCOS, it's more predominantly in the periphery. If the hepatic insulin resistance is mostly in the obese PCOS cohort. Insulin resistance present all, but in obese patients, the hepatic insulin resistance is also quite contributory. And this insulin resistance, along with the associated compensatory hyperinsulinemia, stresses the pancreatic beta cell function that can further predispose these patients to development of prediabetes and diabetes. Along with the insulin resistance, the other major pathophysiological factor in PCOS is the hyperandrogenism. And both of these factors, the insulin resistance and the hyperandrogenism, actually form a vicious cycle in the sense that the increased androgen levels associated with increased free fatty acid actually worsens the insulin functioning, worsen the insulin resistance, and the insulin resistance and the associated hyperinsulinemia further increases the ovarian steroidogenesis and also decreases the SFBG, further increasing the free androgen levels and also increase the pituitary LS secretion. So both of these are the major pathophysiological basis of PCOS, further predisposing these females to prediabetes and diabetes. Other common pathological factors that contributes to both are actually also the mitochondrial dysfunction and also the alteration in gut microbiota. So these are the major, common pathophysiological basis of both the PCOS, which further predispose to prediabetes and diabetes.
Thank you, Dr. Aprajita. As you rightly said, it's all very intricately linked, like hyperandrogenemia can contribute to the pathophysiological manifestations of PCOS that we see, and also prediabetes and diabetes. And it could be a driving factor for both as well, as do many of the factors. So my next question is to Dr. Varun. So how does insulin resistance in PCOS contribute to the progression from prediabetes to type 2 diabetes, and what early interventions can be recommended in this situation? Dr. Varun, is there? So we'll just get back to this.
Sorry.
Yeah.
Sorry. Yeah, I was mute. Sorry. Thank you, Endocrine Society of Delhi team, for inviting me for this wonderful session. So, as rightly pointed out by Dr. Rupali, the basic pathophysiology of the PCOS is the underlying insulin resistance, which is noted not only in the liver, it is noted in the ovaries as well. That is one of the pathophysiological mechanisms behind the PCOS that is occurring. But when you look into the overall prevalence of PCOS, particularly comparing lean versus obese people, the overall occurrence is much more higher in obesity. So that indicates that fat is an important predominant factor for both insulin resistance as well as the progression of diabetes mellitus. So when you look into the people with PCOS having pre-diabetes, it's around for maybe 8 to 10%, but the chances that they will develop diabetes is going to be around 4 to 8%, which means out of like 100, there will be progression in the people with the pre-diabetes to diabetes. The main factors which highly linked with the progressions were: one, the sedentary lifestyle; two, the age of the onset of PCOS and the progression; third, the degree of obesity. If they are the stage 1 obesity to stage 2, the degree of obesity also contributes for progression. Fourth, if they have added features like the features of bit of hyperandrogenism, and if they have the requirement of the multiple pharmacological therapies, and if they have a strong family history, which is also a genetic background behind the chance of development of the PCOS2. So these are the common factors which will make the people with the PCOS progressing from pre-diabetes to diabetes mellitus. So more so when the patient is going to be obese, and if they have late onset, and if they have other associated hyperandrogenic features. And the second part of the question regarding the intervention part of dealing with these kind of progressions, preventing the patient developing pre-diabetes or diabetes mellitus, the first and foremost thing is always recommended from AAC to the other organizations, the lifestyle intervention in the form of an aerobic activity for the patient to start with early in the phase itself, in the form at least 15 to 20 minutes up to 30 minutes per day. And they should be in the form of like running, cycling, or whatever the form they prefer. It's an aerobic activity, the preference, and it should be done at least 5 days per week. And apart from that, the patient can have the sleep cycle should be regularized, at least 6 to 8 hours of sleep, and the sleep should be regularized in the timing as well. And regarding the interventions, the other part is on the pharmacology. As we all know, the pharmacology has a immense implication in preventing the progression as well. So the first and foremost early intervention formula for prevention of progression will be the lifestyle intervention forms, and this is also an important tool that we need to always use in whenever we are treating PCOS.
Thank you, sir. My next question is to Dr. Rupali. So how does the presence of pre-diabetes in women with PCOS affect the outcome of fertility treatments like IVF? Sorry, you're muted, ma'am.
I'm unmute. Am I audible now?
Yeah.
Yeah. So Good evening to all. So when we talk of PCOS and we talk of hyperinsulinemia, I think these are right now, which constitute 25% almost of our patients who have fertility issues. Fertility issues are very, very common in these patients, and they are relatively difficult to treat if there is presence of hyperinsulinemia and more so insulin resistance. If you look at the response of a patient who has been, I mean, there are various studies which have been done with with these patients being put on insulin sensitizers, on metformin, etc., where the chances of the response of a PCO patient, that is, the response to a normal ovulatory drug, also improves in these patients. So definitely their progression from simple management would be like say basic timed intercourse or an IUI towards IVF. Definitely the chances increase because the chances of failure of treatment are higher. And as well as these PCO patients have shown to have a better response to even complications of fertility treatments. If you talk of the IVF patients, and we talk of PCOS who is hyperinsulinemic, if you put the patients on at least 3 months prior to their treatment, if you put them on metformin or any insulin sensitizer, the risk of OHSS, which is one of the main complications in these patients, is much lower. The chances of response is much higher, and we get better number of oocytes when we stimulate them. Apart from that, even later on, the implantation rates are better in these patients who had been previously, insulin resistant and have been managed with some form of therapy.
So very rightly said, I think preconception counseling forms a very important part in the treatment of these patients. If we advise them about the importance of weight loss before starting on therapy, I think that has very good outcomes by itself. So I often see that they're also likely to be overweight when they're starting treatments, and they are very anxious to conceive, that we don't often get that time window to stress upon them the importance of weight loss. But when it is done, I also see that the outcomes are greatly improved, both for the mother and the baby.
Yeah, unfortunately, these patients have a better ovarian reserve as compared to the normal people of the same age group. So we do have that kind of a time where we tell them that, okay, take 3 months, take 6 months, get your weight down, do the entire, it's a holistic approach with diet, with exercise, with a basic overall lifestyle management. And we try to kind of counsel them, send them to a dietitian or other specialities as well. And once they are in a little better state, then only we proceed so that the response is better, so that the outcomes are better. You talk of outcomes in terms of fertility treatments, but our management would go down further as well. It is not about just conceiving, it's about carrying on the pregnancy. Chances of pregnancy losses will be much higher if the patient is, not corrected for her insulin resistance. Then even preterm births, even developing gestational diabetes or preeclampsia, and large for date babies, as well as sudden intrauterine deaths towards the term, which is very traumatic for the patient. So I think most of these people do kind of agree, unless and until they're too anxious and other things. Yeah.
Absolutely. My next question is to Dr. Aparajita. What are the current guidelines for screening for dysglycemia in women with PCOS, and do they differ from the general population?
So according to the recent guidelines, that is the Endocrine Society 2023 guidelines, and even the Androgenesis Society guidelines, they all recommend the troublesome oral glucose tolerance test, that is a lengthy test for diagnosing dysglycemia in this cohort, in this PCOS patient, and just not the fasting and the HbA1c. Because HbA and only HbA1c in the sense that if patient is not willing to or unable to perform an OGTT test, only then HbA1c recommended. Otherwise, OGTT is the standard of care of diagnosing dysglycemia in this patient, because HbA1c in itself does have poor sensitivity for measuring impaired glucose tolerance. And it is actually the HbA1, the impaired glucose tolerance, that is linked to the worsening of the cardiovascular disease in these PCOS group of patients. And if you talk about the fasting blood glucose, it is rather not very sensitive in diagnosing the glucose intolerance in around 58% of the patients who are actually positive with on OGTT. So of course, in these patients, we often, see that we do miss a lot of this glycemia in the PCOS group of patients just by measuring the fasting in HbA1c. So in this patient, a full OGTT must always be recommended and should always be done.
Thank you, ma'am. Dr. Varun, the next question is for you. So I know we spoke about lifestyle modifications in women with PCOS, but are lifestyle modifications alone effective as a standalone treatment in women with PCOS, or do we also need to give them pharmacological intervention?
Yeah, regarding the treatment of PCOS, as we know that it's a syndrome, it's not a single entity, and the as per the guidelines, it's very clear from ACOG to AAC, the lifestyle is the first line therapy for any patient with PCOS, because when you look into the overall the indices, for example, when you look into the reproductive index, the second is the metabolic derangement index, or the anthropometric index. So these are the three factors that we look into when in terms of the effectiveness of the treatment. When you look into the role of lifestyle intervention, it has a high chance for improvement in the ovulation cycle up to 70%. From 19%, there can be an increase in the ovulation index. And when you look into the overall the improvement in the overall the metabolic derangements, it also has a promising results as well. But in terms of the anthropometric indices, there is a plus that the patient is going to have when the patient is put on lifestyle intervention alone. So that is why when you are thinking in terms of achieving the separate entities, the role of medications come into the play. So the medications are very much essential, particularly if you have pre-diabetes, if the patient is having diabetes mellitus, if the patient is having the other metabolic derangements in the form of like dyslipidemia, if the patient is having hypertension, if the patient is having obesity with OSA, or if the patient is having other complications in the form of hirsutism. So the androgenic excess, the features as well. So the main role of lifestyle is being still the first line for any patient with PCOS, and then the medications will be useful and prioritized depending upon the index that we need to treat in any patient with PCOS.
Thank you, Dr. Varun. So my next question is to Dr. Rupali. I know we spoke about a few considerations like weight loss, which we have to take into account when we are planning fertility treatments. But would you like to add any other considerations that one should keep in mind when planning fertility treatments for women with PCOS, so that we optimize both maternal and fetal outcomes? You're muted, sorry.
So one aspect which I think all of us should always keep in mind is the psychological concerns. These patients are usually depressed because they are in a vicious cycle of putting on weight and becoming anovulated. Then these women are usually hirsute. Indeed, hyperandrogenemia is so common, although the phenotypes are there now, and the first three phenotypes are the ones where you have hyperandrogenemia more so, and there you see that insulin resistance would be as high as 80% of the patients, especially in the classical PCO. So these patients really need, I think, a support of a good counseling session, good counselor, so that they can come out, above their thing. Their goals have to be very achievable. When you talk in terms of diet, when you talk in terms of exercise, everything has to be in a very structured manner rather than going in a very haywire manner, which will be a result oriented pattern. And invariably, if the patient is dedicated, they usually at least lose 15% of the weight, which is the usual prerequisite. They don't always have to go up to, I have had patients where the patient was 100 kg, she lost, say, just around 10-12 kgs, and she became pregnant. So that's the way we have to counsel them, rather than telling them that, okay, you have to lose 40 kgs to get back to their normal weight. And that's the, I think, key behind it. Apart from that, yes, they're all aware of the fact that these things are very disturbing in terms of outcomes. When you talk of fertility outcomes, you talk of pregnancy outcomes, they can be detrimental. But I think a positive counseling, smart, achievable goals, and a multidisciplinary approach together with the counselor, together with the dietitian, together with the endocrinologist. All of us need to be working together on the same platform and guiding the patient so that they are more driven towards it, and they do achieve. Many patients do achieve the required goals.
Thank you, Dr. Rupali. So just to summarize what we've spoken in this session, women with PCOS come to us with cosmetic concerns, often with concerns related to reproduction. We, of course, address all of this, but what I would also like to stress upon is that PCOS is also associated with high cardiovascular risk. And one of the cardiovascular risk is prediabetes and diabetes, as we have spoken today, but it is also associated with various other cardiovascular risk factors like dyslipidemia, presence of hypertension, presence of OSA, obesity. So we should also be evaluating these cardiovascular risk factors in women with PCOS. This is in fact a window of opportunity because the patients are presenting to us with some other concerns, but we have a great window of opportunity to intervene and optimize their risk factors. So thank you, Dr. Rupali, Dr. Varun, and Dr. Aparajita for that great discussion and insights on prediabetes and PCOS. And I now hand over to the organizers.
Thanks to
you, ma'am, and thank you all the panelists for sharing your views on such a relevant topic. I next invite Dr. Anshita Agarwal, Associate Professor in Department of Endocrinology at RML Hospital, Delhi, to discuss about the topic pre-diabetes and obstructive sleep apnea. I also welcome the panelists for this discussion, Dr. Srinath Shetty, Associate Professor Endocrinology at KMC Mangalore, Dr. Himanshu Sharma, Consultant Endocrinologist at Rajiv Gandhi Super Specialty Hospital, Delhi, and Dr. Kshitij Agarwal, Director Pulmonary and Critical Care Medicine, the Institute of Health and Lung Diseases, Delhi Hospital, Bahadurgarh. Dr. Anshita Agarwal.
Yeah, hi, good evening, everyone. So till now, we have had a lot of discussion on the various different spectra of pre-diabetes and how it is not a simple or a very innocuous entity that it was thought for so long. So now coming to a topic which is very important, very pertinent, but somehow I feel it is very neglected. The patients also probably are not aware about the symptoms and what exactly they might be facing. So we'll be talking about obstructive sleep apnea in the context of pre-diabetes, and we have a distinguished panel of experts, 3 experts with us to discuss this. So without wasting any further time, I'll begin the discussion starting with Dr. Kshitij first. Sir, good evening, sir. Sir, for starters, let us start with what exactly is obstructive sleep apnea. What are its symptoms and what are the various diagnostic modalities that are used to detect this?
Here and I'll start with the definition of OSA just to make a headway over it. So to put it simply, obstructive sleep apnea, as the name suggests, is a partial or a complete cessation of breathing due to a collapse of the upper airway during a sleep cycle. So having said that, it should be understood that the only part of the airway that is amenable to collapse is the unsupported muscular part of the airway, that is the pharynx. Since above that you have the nasal cavity, which is a bony structure. Below that you have the trachea, and which is a cartilaginous structure. So the culprit the problem of the issue lies with the pharynx. Put it further simply, it could best be understood by the fact that there, particularly in a case of say obesity, where there's excessive soft tissue deposition around the neck. So this predisposes the person to have an airway collapse when he reaches a state of atonia during sleep cycle. So since I use the words partial and or complete collapse of the airway, this brings us to 2 further definitions, that is apnea and hypopnea. So apnea would best be defined by a complete cessation of breathing for at least 10 seconds. And hypopnea in turn would be defined as at least more than 30% reduction of breathing from the baseline, 30% reduction of airflow from the baseline for more than 10 seconds, associated with at least 3% of peripheral arterial desaturation, or also associated with the arousal on the EEG. When we come to symptoms, so we would, the classical presentation would be that of a middle-aged, pot-bellied male who has a BMI of say above 30 or is overweight or is in the morbidly obese category. And he would have a gamut of symptoms that encompass not only nocturnal, also extend into his daytime activities. So his nocturnal symptoms would be very classical of loud snoring, of the partner being disturbed during his snoring, or having excessive limb movements during snoring, tossing over in the bed, having recurrent nocturnal enuresis. But when you compare, but more distressing for the person would be the diurnal symptoms, which would be something like excessive daytime sleepiness, which is considered a hallmark of this disorder. So much so that the person may also be predisposed towards road traffic accidents, having fallen asleep on the red light. Further, he could have very inane sort of symptoms such as mood irritability, poor cognitive function, or even loss of libido. So I mean, the symptoms are very inane, and it usually predisposes one to not seek medical help, since these are symptoms that one just associates with the routine stress of life. How to diagnose this is a bit tricky. First of all, every physician would need to have a high risk of suspicion, seeing this particular body habitus. Of course, I said it has to be a pot-bellied male, but that is obviously not true, as with everything else in medicine. The prevalence of OSA rises after menopause in females as well, and it may also approach the male level. It may reach a level of 1:1 after menopause. So when we are talking of diagnosis of OSA, even though the AASM, that is the American Association of Sleep Medicine, does not, or rather categorically does not promote screening, but it would still be a good starting point to perform a screening test. We have a lot of questionnaires, but the three most prevalent questionnaires in this regard are the Epworth Sleepiness Scale, which helps us to distinguish whether the person is actually sleepy or fatigued. So once the Epworth Sleepiness score gives you a score of above 11, you know you're dealing with a genuine excessive daytime sleepiness. And to complement that, there is something also known as the fatigue severity score. So that would help you rule out fatigue. One more questionnaire which has even more specificity and is even more easy to administer is called the STOP Bank, STOPBANG. So S stands for snoring, T stands for tiredness, O for obstructive events, P for blood pressure. So once the answer to any of these is a yes, a score of above 2 would predispose a person to having a diagnosis of OSA being likely. A score of above 3 makes it even more likely. I mean, pushes them into the severe category. So, and then BANG is again a B for BMI, that is more than 30. G stands for gender. D stands for gender, N for neck circumference, and A for age, that is above an age of above 50. So this is this is about the screening. And once you have a suspicion on screening, the next phase that follows is the diagnostic modality. Classically, what the book describes as the gold standard is a level 1 polysomnography, which is classically performed in the laboratory, in a sleep laboratory in a hospital. So you have multiple channels that are measured in that. That is the electroocculogram, the electroencephalogram, the ECG. You have respiratory thermistors, pressure sensors. So a multitude of events is measured across the sleep cycle, and depending on what parameters we observe, you provide a numerical value which is called the apnea-hypopnea index. That is the number of apneas and hypopneas that occur during the entire phase of the sleep, the entire phase of sleep that has been recorded. So by definition, an AHI of above 5 would label a person as having OSA. Further, you can perform a severity grading based on this. So 5 to 15 would be mild, 15 to 30 would be moderate, and above an AHI of above 30 would be a severe OSA. And apart from this, you have wearable technology that is coming in now, since you have all these sensors and the wearable watch devices and all those things. So this has also seeped into sleep medicine well now. So we have something that is known as the home-based sleep apnea testing. Again, sort of measures the same thing, but it relies only on 3 things, that is airflow, effort, and oxygenation, that is the oxygen saturation. So you are able to derive a similar sort of index, similar to AHI, out of home-based SAT. And there is another thing, that is the peripheral arterial tonometry, which is just like a wearable watch. And it measures the changes in the pulse amplitude with the sympathetic tone outflow during the REM cycle or the NREM cycle, and that is how it gives a result. So this is in short about the diagnosis, presentation, and the definition of OSA. Thank you.
Thank you, sir. It was really comprehensive and you covered most of the important things. So now we know about OSA, what it is, how it presents, and how we diagnose it. So I'd like to ask Dr. Himanshu, sir, what can you apprise us of the risk factors for OSA? What are the various risk factors, and in turn, how OSA impacts our health status adversely?
So basically, obesity is one of the major risk factors for obstructive sleep apnea, especially as already discussed, visceral fat and the fat that is actually particularly on the neck that causes more OSA symptoms. Then there are some factors that are non-changeable. So age, elderly age, male gender, and presence of family history. These are factors that can lead to increased risk, but there are tonsils, a deviated nasal septum, or a thick neck circumference also add on to the risk of OSA. Now, along with that, increased smoking and alcohol consumption, along with medical conditions such as hypothyroidism, are also considered to be at higher risk of developing obstructive sleep apnea. Now, the presence of obstructive sleep apnea is actually associated with a multitude of cardiovascular problems, including high risk of hypertension, heart attack, stroke, and atrial fibrillation also. The drop in oxygen that occurs can cause to an increased incidence of ischemic heart disease along with that. Coming to lungs, there is an increased incidence of asthma, COPD, and cerebral infarct. With that, there is an psychological comorbidities of stress and depression also increase in such patients.
You are muted, ma'am.
Sorry, it was on mute. Yeah, I was just asking, sir. And what about? So you mentioned various risk factors and how it impacts us. So does it impact the glycemic status also of a person having obstructive sleep?
Definitely, obstructive sleep apnea is actually associated with a higher risk of dysglycemia and an increased prevalence of metabolic syndrome in most of the patients.
Right. Sir. So, sir, you mentioned the various risk factors and how it is affecting us. You told us that it can lead to metabolic syndrome as well. So now there is a lot of data. I believe that probably we can say. I would like to ask Dr. Srinath about this. So, do you feel it will be right to say if we say that the relationship between obstructive sleep apnea and metabolic syndrome, it is not a unidirectional relationship? Is it a bidirectional relationship? Would that be correct to say?
Yeah, that's an interesting point. Previously, if you add obstructive sleep apnea to the metabolic syndrome, it was called syndrome Z. We have syndrome X for metabolic syndrome. So syndrome Z was metabolic syndrome with OSA. But then it was taken out, and now we deal with obstructive sleep apnea as a separate entity, but it is actually an extension of your metabolic syndrome. It increases the same complications that we see: cardiovascular complications, diabetes, obesity, dyslipidemia. And it works both ways. Your things that are associated with metabolic syndrome, say hypertension, prediabetes, cardiovascular problems, these worsen obstructive sleep apnea. At the same time, obstructive sleep apnea worsens these disorders. For example, obstructive sleep apnea patients, they have a higher sympathetic drive because they get up so many times at night, and this activates the sympathetic nerve system, and thus they can come with early hypertension. We see some patients not responding to classical antihypertensive drugs, one or two drugs, and that's when you dig more. Many times we get reference to rule out secondary causes. They think about FEO or cons, but it turns out to be obstructive sleep apnea which caused that resistant hypertension. And these patients classically, they have a non-dipping nocturnal kind of hypertension. And diabetes, so as you just now spoke, that OSA increases the risk of diabetes, and a lot of diabetic patients in fact have OSA. And patients with diabetes who have bad neuropathy, these patients have a bad carotid receptor mechanism. So these patients tend to have a bad OSA, and this bad OSA itself can cause increased insulin resistance, hypoxia causing beta cell dysfunction, and because of constantly getting up, their cortisol axis is overactivated, and that's why they're more insulin resistant, and inflammatory cytokines are elevated. So we see there is a crosstalk between these OSA and its complications. Similarly, we see that there are a lot of studies where it has shown that OSA patients tend to have higher LDL, low HDL cholesterol, high triglycerides, and we also talk about obesity as a risk factor for OSA. But it has been seen that patients who are having obstructive sleep apnea tend to be more obese. In fact, when you start treating them with CPAP, you see that they start losing weight. Hypertension also becomes better. That's because the overall energy expenditure is more, but at the same time, they have higher appetite, and the cytokine levels are on the higher side. So they tend to retain weight rather, though they are losing more, they tend to eat more also. So that's why it's a bi-direction relationship, and you have to look at the complications when you're dealing with it. Thank you.
Right, sir. Thank you, sir. So, sir, we talked about OSA, its relationship, its complicated relationship with metabolic syndrome, and you mentioned how treatment can actually improve the metabolic syndrome parameters as well to an extent. So now that we touched upon the treatment, I'd like to ask Dr. Shutish, what are the various treatment modalities that are used in the treatment of obstructive sleep apnea?
So the treatment of OSA theoretically has two components, that is the non-surgical and the surgical part. So it is very easy having said that, but in practice it is anything but. When we talk of the non-surgical sort of management, there are again two things that you have to focus on. One is the lifestyle modification. Since OSA in a way does have a component of lifestyle related diseases, so weight loss obviously forms the crux of management, which again is easier said than done. So apart from lifestyle, apart from weight loss, a calorie deficient diet, general sleep hygiene measures, avoidance of any stimulants or respiratory depressants such as alcohol, nicotine, drugs, opiates, all those things have to be advised without fail. You can also use certain other measures depending on the underlying pathology that has turned out during the examination. So suppose you have a patient that has been suffering from OSA, particularly during the supine position. So this patient can be advised to start sleeping in a prone on a semi-recumbent position. But the crux of management ultimately relies on a positive airway pressure therapy. Classically, it is the continuous positive airway pressure therapy, or the CPAP, which is the backbone of management in OSA. But the problem with CPAP again is, since it leads to a lot of oral dryness, it leads to a lot of xerostomia, pressure sores, or depression of the nasal bridge. The compliance with that eventually reduces with time. So to compensate for those things, the newer modalities kind of auto titrate the pressure depending on the airway collapse, the required pressure to open the airway during a collapse. So this is the newer thing that is coming up. Rather, it is already established into the market. And then you have other non-surgical measures such as mandibular advancement devices or nasal pillows, which are particularly important in cases where you have a nasal cause of an obstructive sleep apnea, such as a DNS, or an excessively patulous uvula, or mandibular advancement devices, particularly where you have cases such as retronathism, which predispose to a shorter airway segment. And then finally, surgery, the surgical causes are there. I mean, the surgical modalities are there. Classically, we have two surgeries, that is uvulopalatopharyngoplasty, UPPP, what it is abbreviated as. That is already there, but that is also something that leads to a recurrence of OSA over time if the general routine, if the backbone measures have not been advocated. And then we have something called the maxillomandibular advancement surgery, which is again used in cases of retronathism or pronathism. Then another thing that is coming up is what is known as the hypoglossal nerve stimulation. So hypoglossal nerve stimulation leads to the positive feedback in the respiratory loop. But there are certain contraindications to it, such as a person who is morbidly obese, or person who has an unstable cardiac profile, who is in present heart failure. I mean, it is again not available at it's not available at every nook and corner. So this again in our country stays at least a research in a research phase. Sadly, pharmacological measures have not been shown to conclusively have a role. You have, I mean, all the pharmacological studies that are, all the studies that are using pharmacological measures have been targeting three components of the syndrome. That is to improve the upper airway muscle, to improve the respiratory muscle tone, improve the arousal threshold, and improve the respiratory drive. So you have diuretics such as acetazolamide, which have shown some promise. You have anti-diabetics, the GLP-1 inhibitors such as the liraglutide or semaglutide sort of drugs. But it still stays anecdotal, and nothing has been put to complete test for now. I mean, to summarize, the positive airway pressure is what stays as the back.
Right. Thank you, sir. So now that we've talked about the treatment, I'd like to ask Dr. Himanshu, sir, do we have any evidence that if you're treating OSA, is it going to retard the progression of pre-diabetes towards diabetes?
So yes, there is scientific evidence available. The evidence is available both on the pathophysiological levels and the clinical studies that are available with us. So basically with OSA, we need to understand why there is insulin resistance with OSA. There are many factors that improve when you treat OSA. First, that intermittent hypoxia and sleep fragmentation that occurs actually causes more inflammation and oxidative stress in the patient. These are two factors that are commonly associated with insulin resistance and an impaired glucose metabolism. Similarly, most of these patients, sympathetic nervous system activity is increased, which is effectively reduced when you put your patient on a CPAP treatment. Now, this reduction in sympathetic nervous system activity is important because the overdrive of sympathetic activity has been associated with increase in glycogenolysis and gluconeogenesis, which contribute to, again, insulin resistance. Similarly, severe OSA has also been seen to be associated with activation of several hormones such as counter-insulin hormones of cortisol and epinephrine, which actually exacerbate the hyperglycemia. All in all, we have that the poor sleep deprivation and poor sleep quality that are associated with the circadian rhythm disruption have a negative impact on the pancreatic beta cell and insulin sensitivity itself. Now, coming on to the clinical evidence, there are multiple trials even from the Indian population. We have a trial from SKIMS of around 62 patients that prove that treating OSA actually leads to an HbA1c reduction of 0.5. Now, coming to a larger trial, this was a SAFE trial that was done in around 2016, and the trial was sleep apnea cardiovascular endpoint trial. Now, this was basically a trial in which they took around 3,000 OSA patients, of which around 500 had pre-diabetes. Now, those patients who had pre-diabetes and severe OSA, their HbA1c reduction was significant with a mean fasting plasma glucose reduction of around 18 to 20 milligram per deciliter. So there is a definite evidence that when you treat OSA, you are reducing the chances of progression to diabetes in a pre-diabetic patient.
Right. Thank you, sir. So that is quite encouraging and nice to know. So we talked about treatment modalities, lifestyle interventions, and how pharmacological therapies are not very helpful. But coming to the different aspect of OSA with respect to diabetes. So Dr. Srinath, I'd like to ask you, if a patient has OSA and pre-diabetes, is there any role of specific anti-diabetic medications in this condition?
So when you have pre-diabetes and OSA, you know that the risk of progression of pre-diabetes to diabetes is much more likely. So, but the drugs that have been tested in this group is very less actually. In EMPA-REG trial, they looked at some patients with OSA. So almost, I think there are a few, almost 10% of them had OSA. And what was seen is the outcome wise, both of them had a good cardiovascular outcome. It was comparable. But patients who are on EMPA-REG, the new onset OSA was less common compared to patients who are not on empagliflozin. And there are some trials which have looked at SGD2 inhibitors, other SGD2 inhibitors in OSA, whether it is helpful to treat OSA. But the results are promising, but you don't need more studies to look at it. And among other oral anti-diabetic drugs, are tirzepatide, that is Monjaro, which is not yet available in India. There's a Surmount OSA study going on, and it has shown very promising results. It can be used in patients with OSA without diabetes also, and it's yet to come, of course. And even semaglutide, there are studies going on where they're looking into obstructive sleep apnea and OSA in non-diabetic individuals also. And again, here studies are they're positive. They work main is through weight loss. The other thing is they also work on the central mechanisms. GLP also has a central role, so it acts on that. The other drug that has been tested both for pre-diabetes and OSA is metformin. It's a common drug. There are some positive response, but it is not recommended now for all the patients who have OSA and pre-diabetes. So you have to take an individual call. So overall, I would like to say there are promising drugs, but yet to have come in the guidelines or therapeutics to decide on medications.
Thank you, sir. So this has been a very insightful session. Just to summarize very quickly what we have learned today. So we learned that obstructive sleep apnea is a condition that is characterized by symptomized loud snoring at night, daytime sleepiness, and fatigue. There are various diagnostic modalities for the same, and the relationship between obstructive sleep apnea and prediabetes, or for that matter, any other component of metabolic syndrome, is bidirectional. So it is promising to know that if we treat obstructive sleep apnea, and by treatment we mean a lot of role of lifestyle interventions, wherein weight loss via diet changes, exercises plays a very important role. So if we are treating obstructive sleep apnea, we can actually retard the progression of pre-diabetes towards diabetes. And apart from that, it is also helpful to note that now we do have certain medications, though as sir mentioned, more studies are needed, which can actually play an important role in patients with OSA and prediabetes, though the role is limited, the knowledge of it is limited as of now, but SGLT2 inhibitors and certain GLP-1 analogs are of help. So with this, I think we come to the end of our session. Any take-home points any of our panelists would like to share? Otherwise, okay, so I'd like to pass on the mic to Dr. Lavina. Thanks a lot to all the panelists for their expert opinions.
Thank you,
Thank you, ma'am, and thank you all the panelists for an engaging discussion on this topic. I now call upon Dr. Saptarshi Bhattacharya, Honorary Secretary of Endocrine Society of Delhi, to give the vote of thanks.
Thank you, Lavina. So we really planned this on a very short notice, and first of all, I should be thankful to all the faculties who agreed in 4 or 5 days request that please join us, and they did all of them did a wonderful job, and we're really thankful to them. And so we start with Dr. Wangnu, who has been the founder president, and then Nishant, who has been really active as a treasurer in Endocrine Society of Delhi. Then Dr. Amrish Mittal, who is the current president of Endocrine Society of Delhi. Then we had Dr. Parjeet, Dr. Lakshmi, and Dr. Anshita moderating the panels. And we also have had all eminent panelists, and it was good to have inputs and insights from especially people from cross discipline. So we keep on having endocrine discussions, but it was really wonderful to have Dr. Narendra and Dr. Rupali and Dr. Kshitij Agarwal from different specialties joining us here. Obviously, we also had Dr. Mohammad Shafi Kuche, who is himself has multiple publications. He has even presented in ADA. He has a lot of research work on NAFLD, which is now MASLD. Dr. Anupam was there, Dr. Varun and Dr. Aprajita, they were also excellent. Dr. Himanshu, Dr. Srinath, thanks for joining. So a great, huge thanks to all of them. Also, we are grateful for our back-end support. So Bashir and we have collaborated with him, the Centrex team for Endocrine Society of Delhi. So they have been looking after our website as well. So thanks to Bashir and Sham and all for making this program run so smoothly. And all thanks to all the delegates for joining in. So Pre-Diabetes Day celebration, it's we all celebrate World Diabetes Day, but this is something where we actually need to focus. So if it's like somebody is diagnosed having to have type 2 diabetes, is already 70-80% of the insulin secretory capacity is gone. This is the time where you actually need to intervene if you want to prevent diabetes from manifesting with all its full-blown complications. So this is something thanks to ESI, our central guiding body. So we are grateful to be part of the ESI Endocrine Society of India central team. So we look forward to having more such meetings in collaboration with ESI central team, and thanks to everybody in Delhi NCR who are all very important message for everyone that pre-diabetes is the area where actually we can make a difference, because if you are having diabetes, it's already already the disease has gone to that stage where it's more advanced. So this is a time to intervene. This is a time to be more proactive and prevent future complications and have healthier life. Have a very, very happy Independence Day. Jai Hind. Thank you for joining.
Thank you, sir.